Alright, I think we might be able to finish this whole set with this last recording. Cardiomyopathy literally means disease of the pumping muscle of the heart, right? Just like myocardial infarction is the muscle mass of the heart. Well, cardiomyopathy, again, just disease of the heart and the heart muscle itself. 95% of it is dilated cardiomyopathy. So we've talked about hypertrophic disease. Well, more commonly with cardiomyopathy, the heart muscle wall starts to dilate, starts to thin out. So if you remember the slide I showed you before about the ventricular aneurysm, well, if your ventricles really aren't strong and the muscle has literally wasted away and thinned out, well, that's going to affect your stroke volume. Your stroke volume is going to go down dramatically. Your ejection fraction is going to go down dramatically. And you're going to end up in congestive heart failure. Not a lot you can do most of the time with dilated cardiomyopathy. Not a whole great amount of material to go on pathophysiologically. A lot of times it's a virus. You'll see this a lot of times in children who need cardiac transplants. There's also hypertrophic obstructive cardiomyopathy, which used to be called subaortic cardiomyopathy, hypertrophic subaortic cardiac myopathy. And restrictive cardiomyopathy means exactly what it sounds like. The left ventricles lose their elasticity. So you see this with things like amyloidosis, sarcoidosis, infiltrative diseases in the heart. Infections can also affect the heart, pericarditis, endocarditis. You can also see a myocarditis, but that's more commonly an inflammation, usually following like a myocardial contusion or heart trauma. So pericarditis, right, inflammation of the pericardial sac, and this can happen from a variety of reasons, whether it's an infectious cause or not. And endocarditis, seen most oftenly with things like valvular regurgitation, valvular vegetation, so things like acute bacterial endocarditis, subacute bacterial endocarditis. So you will see with different issues there, and I'll come back and speak to them. I know in the downstate group I started asking if anybody had really done any work with the endocarditis and talked about things like Janeway nodules and splinter hemorrhages, little bleeding like splinter black and blue marks in the fingernails, which goes along with endocarditis. Peripheral vascular disorders should not be surprising anymore. The entire theme of the whole cardiac lecture has been the cardiovascular system is the same hose, the same pump, whether it's in the foot, whether it's in the penis, whether it's in the brain, whether it's in the carotids, whether it's in the coronaries. The same inflammatory cascade is going on. So you're going to get cholesterol deposition, you're going to get increased vascular resistance, you're going to get intimal lining issues, you're going to get Virchow's triad problems, whether it's in the ankle or the elbow, the foot or the heart or the brain. You got to remember that the vascular system is one system. So it's very hard, it's going to be very rare to see, got a little cold, to see heart disease in the absence of brain disease, and to see peripheral artery disease in the absence of carotid artery disease. So PAD, or peripheral arterial disease, sort of think of things like leg angina, where you have leg pain with exercise, and then as it progresses, you have leg pain with rest. ED is erectile dysfunction, which is PAD is a significant risk for having an MI. And ankle brachial index of less than 0.8 indicates more severe disease. Ankle brachial index is simply taking the blood pressure in the arm and taking the blood pressure in the leg. You do a small equation. It should be about 1 or so. You should have the fairly same or close blood pressure in the leg as you do in the arm. And if you have decreased blood pressure in the leg, it means you have peripheral arterial deficiency, and that's going to be a problem. Varicose veins we talked about earlier, and deep vein thrombosis. On its surface, the most important thing is going to be its increased risk factors for pulmonary emboli and increased risk factors for cerebral emboli. If we take a look at aortic aneurysms, whether they be thoracic or abdominal, typically your awake patients will complain of tearing, ripping, sort of Velcro-like pain, whether it's in the abdomen or in the back. You'll hear about a classic pulsatile midline mass if you do a good physical exam, and if it's still there, if it's actually there in the first place. Also, you need to remember that these are for your patients who are A&O times 3, and have really no other disorders going on. Sort of how we talked about diabetics aren't going to feel normal sensation. Also, if your elderly patients have a normally decreased mental status, they might just be screaming in agony, have no idea why, or just crying. If the patient's already unconscious, not going to be complaining of tearing, ripping pain. These are things you have to evaluate. Excuse me. And again, when we talk about aneurysms, when we talk about now with things like causes of death and what's going on, having an aneurysm is fairly common, and it doesn't mean that it's necessarily clear the OR, run, run, run. We talk about either having the aneurysm, or the aneurysm is dissecting, or the aneurysm has ruptured. So if we take a look here, right, so there's an aortic aneurysm, and here's an aortic aneurysm, and here's, excuse me, sorry about that, and there's aortic aneurysms. So patients will show up with these. You'll be doing x-rays of the lumbar spine for a 68-year-old lady who just got into a car accident. It'll come back that there's an aortic aneurysm, that there's calcification. You'll be doing other studies, and it'll show up that there's an aortic aneurysm. These things, it just means that there needs to be further study, unless the patient's actually complaining of chest pain or belly pain or back pain, where this might actually be dissecting, which means slowly, relative term, opening from highest pressure to lowest pressure. If it's a rupture, what we really mean is you take a pencil and you just stick it right in there. Then the mortality obviously is much, much higher. Though this means the person's already in the OR as this ruptures, then they might have a chance, if you can do sort of cross clamping and move on. They don't have high chance of infection, etc. So the thoracic aorta can either be an ascending or a descending thoracic aorta, very commonly complaining of tearing, stabbing, chest, or back pain. Their blood pressure and pulses might be asymmetrical, which is why it's always the best job initially taking bilateral pulses and bilateral blood pressures to see if it's symmetrical or close to symmetrical. In class, I told all of you the stories about Jonathan Larson and John Ritter. And also, we'll talk about Marfan syndrome, and we'll come back to it. Marfan syndrome is a connective tissue disorder. And the connective tissue we're talking about here is specifically fibrillin, where we're trying to make up the blood vessels. And the blood vessels very commonly are weak in people with Marfan syndrome. They are very prone to aortic aneurysm. If they know they have Marfan syndrome and they're having chest pain, they're going to tell you. Marfan Syndrome Association does a big education issue with telling people about this. This is a widened mediastinum on a normal chest x-ray. This is one of the things that you're going to look for, is one of the reasons why you do a chest x-ray in your chest pain patients. Not really saying, oh, that person's having an MI, but oh boy, this is not an MI. This is something I need some more help with. And this is probably a reason not to give TPA. And we're going to end up with a couple of slides on what the endothelium actually is, and just to try and go over things with you. So the endothelium, if we look here, produces vasodilators and vasoconstrictors, procoagulants and anticoagulants, inflammatory and anti-inflammatory, fibrinolytic and antifibrinolytics, oxidizing and anti-oxidizing agents, depending on whether it's been damaged or not. Okay, when the endothelium lose their ability to maintain this balance, the conditions are right for the endothelium to be invaded by lipids and leukocytes. Think about foam cells, macrophages, oxidized LDL, the beginnings of atherosclerosis, which begins the peripheral vascular resistance, which increases the blood pressure, which increases shear tension. You see where I'm going with this. The inflammatory response is incited, fatty streaks appear. Okay, leads to rupture for vascular occlusion. Nearly all stimuli that produce vasodilation do it through nitric oxide, which causes vasodilation. Nitric oxide reduces vascular permeability. Nitric oxide reduces monocyte and lymphocyte adhesion molecule synthesis. Nitric oxide reduces platelet aggregation, tissue oxidation, tissue inflammation, activation of thrombogenic factors, things that are going to make you clot, cell growth, proliferation, and migration, pro-atherogenic and pro-inflammatory cytokines. Okay, so nitric oxide is considered the anti-atherogenesis molecule, the anti-atherogenic molecule, which favors fibrinolysis, favors the breakdown of these clots. So it shows you how important nitric oxide is. And when the endothelium is damaged, it turns off this ability to be secreting nitric oxide. You're setting up pro-heart disease and pro-cardiovascular disease issues inside the vascular system. The endothelial cell reduces angiotensin II, which is basically all these bad things: vasoconstriction, prothrombogenic, if I could read, oxidizes and has anti-fibrinolytic effects, favors leukocyte adhesion, okay, favors stimulating endothelin converting enzyme, which releases endothelin 1, which is a very powerful vasoconstrictor. It stimulates nuclear factor kappa beta replication, which leads to the production of pro-atherogenic cytokines, tumor necrosis factor alpha, interleukins 1 and 6, chemokines, inhibits nitric oxide production, okay, favors synthesis activity of angiotensin II. Okay. This amplifies the inflammatory response. Remember that native LDL molecules don't do anything, but this oxidized LDL has all of these harmful effects, which I'm not going to read through. I'll just show up here because I'm trying to run through this and finish this up. And if we look at the pathophysiology of hypertension and diabetes, right, we have overproduction of vasoconstrictive factors. They increase the vascular tone. Reduction in the activation of and the actions of vasodilators, read that as nitric oxide, resulting in the increase in blood pressure. Causes structural damage. Causes hyperplasia, angiogenesis, apoptosis. And then we talked about reactive oxygen species, right? In diabetics, increased metabolic processes that produce reactive oxygen species. Free radicals stealing their electrons to stabilize their outermost shell. What does insulin resistance do with endothelial dysfunction? And very last, what each molecule of fat releases. So each molecule of fat releases angiotensin II, tumor necrosis factor alpha, PAI1, which is the opposite of TPA, which is a pro-clotting agent, C-reactive protein, resistant leptin, which we'll talk about another time, visfatin, which we'll talk about another time, free fatty acids, and interleukin 6. And that finally ends cardiovascular.